So I'll be discussing on modern day debate on graft choices. So we know that the consensus for management of an ACL tear in an acutely injured knee in a young active individual remains in ACL reconstruction. But what consensus we don't have is what graft to use. And that is purely because of the diversity which is available globally. So what might be a gold standard in the Western world need not necessarily be a gold standard in the Indian scenario or in the Asian population. We also know that ACL reconstruction has undergone a massive shift, right, from transtibial to a transportal, a single bundle to double bundle, coming back to a single bundle or more anatomic, as to say, a BTB graft going to a soft tissue graft, and also in addition to this, various modalities of fixation, because this all has an effect on the choice of graft that you would make. So effectively, what are we trying to answer in these next 10 minutes? What we need to do is we are trying to reproduce native anatomy. And native anatomy is variable. There is a lot of variation depending on the patient demographics, patient subset. We are looking at different cross-sectional areas. We're looking at different volume. And when so much of variability is there, how do we get to the holy grail? How do we restore what is native? So what are the choices we have? We have either an autograft, we have an allograft, and we have an artificial graft. So when you're looking at autograft, you're effectively having your own tissue. If you're considering an allograft, it's someone else's tissue, and then you have a synthetic graft, which is an artificial graft. So the point to ponder here is that if it was your own ACL, which is the graft that you would possibly consider? When in India, the options that we have amongst the autografts, you have the BTB, which is considered the gold standard over years together now. You have the hamstring tendons, the so-called soft tissue graft. You have the quadriceps graft, which could either be with or without a bone plug, or you have the peroneus longus, which is really gaining momentum. What about the allografts? You can either use the Achilles tendon, you can use the patella tendon, or you can use the tibialis tendons. What about each of these grafts? Each of these grafts have pluses and minuses. So BTB over the years has stood the test of time as a gold standard. Why so? Because we know bone heals to bone quickly. So it's a stiffer graft, does not really stretch out that easily. There are no hamstring problems. And if you're looking at a high demand athlete, someone who's involved in collision sports, and in India, you're looking at something like kabaddi or someone like who wants to wrestle, probably this would be an ideal graft over a soft tissue graft. What are the flip sides to it? Graft harvest is not something which is easy. You need to have a learning curve and you need to do it right. It takes a little longer to harvest this graft. There is a debate on whether in kneeling population would you want to consider this graft because it may cause some amount of anterior knee pain. Arguably, proponents say that it really does not make much of a difference. What about the hamstrings? The hamstrings over the last probably 2 or 3 decades has gained so much of momentum that the new surgeons are possibly just used to harvesting the hamstring and not even used to harvesting the patella tendon. It's a quick graft, reliable, you can have a smaller incision, cosmetically it's more acceptable, and early rehab is not too bad. But the flip side to it, it can cause subtle hamstring discomfort. The graft does get weaker as it revascularizes. Fixation to bone is a challenge because here the graft is healing only to the mouth of the tunnel and there is no bone to bone healing. It can stretch out a little as compared to the BTB, and graft size is not predictable. The quad tendon has started gaining a lot of momentum again, which was earlier a choice of graft, had dropped down in between, but now many of the surgeons do consider quad tendon, if not for primary, definitely for a revision surgery. It's a strong graft. It may have less morbidity than a BTB, but the weakness to it is that you don't want to touch the extensor mechanism as much. Can cause anterior knee pain. But what you need to understand here is that one of the slides that I said, when you're restoring native anatomy, you want to restore the cross-sectional area as well. So if you look at the density or the cross-sectional area of a BTB compared to a quad tendon is going to be much more thicker, more collagen which is there, and that's something which is helpful. It cannot be without talking about the peroneus longus, and I know the Western world is not a big fan of using the peroneus longus, but there are a lot of papers coming up from Asian subcontinent about use of peroneus longus. It's an absolute easy harvest. You get a long tendon. It may be useful for multi-leg instabilities and may have less morbidity. What is the flip side? Do we have long-term data? Well, not really. Second thing, it is not used globally. And in ankle, does it cause ankle instability? There is no conclusive evidence on that. A worthwhile read from Journal of Isocos last year, where the authors have clearly mentioned that there is insufficient evidence to support its use in kneeling population and especially in ACL with MCL. So it's not something which you would use routinely as a first choice graft. What about allografts? You have the BTB, the Achilles tendon, the hams and the quads. If you look at this paper, it clearly states that in repair of ACL tears, allograft reconstruction is as effective, but revision rates or tunnel widening is much higher when it comes to allografts. So let's try to compare apples with apples. So when you look at allograft and you look at autograft stability, allografts have significantly normal or lower stability rates as compared to an autograft, and allografts will show 3 times lesser stability as compared to autografts. Likewise, if you're looking at only soft tissue grafts, again, there's no significant difference in this meta-analysis when you're looking at soft tissue graft using a hamstring vis-a-vis autograft and allograft. Likewise, when you're again looking at a BTB autograft versus allograft, again, when you're looking at patient-related outcome measures, there is a high satisfaction rate in both the patients, and that's the reason why it is said that probably not much of a difference, but in the younger patient, you would have to use it with more of caution. What about artificial grafts? They have been around. They were on the decline. Again, it's gaining some amount of resurgence. Now, what you need to understand about artificial grafts is it can either be used as an augmentation device or it can be used as a standalone ACL recon. The Leeds Clio ligament was the first one which came into picture. The idea was a polyester mesh intended to act as a scaffold for soft tissue ingrowth. Good early results, but long-term results for something which were again debatable. The Kennedy ligament augmentation back in 1980 was something which was used. Idea was to protect the graft. Again, resulted in a lot of synovitis and failures later. The last ligament gained a lot of momentum, that is the polyethylene terephthalate ligament. The idea was it had an intra-articular twist, allowed for ingrowth. So biomechanical testing was great, but the problem was these fibers would get trapped between the femur and the tibia, resulting in a lot of synovitis. And that's where the Jewel ACL has now come up with the idea of having a woven pattern, an open tubular pattern, which allows to encase the graft, and that prevents the loose bundles to go away. Do we have long-term data on it? Still debatable, so really literature is not either in favor or against. So where does that leave us with? Successful outgraft with autograft, no proprioceptive differences, greater stability with autograft, greater likelihood of infection with allograft, decreased donocyte morbidity, and overall success is better with autograft. But then is allograft really that bad? No. If you look at revision surgeries or if you look at multi-leg instabilities, that's where probably you can look at allograft as a valid option. So which is a better graft? Does literature really tell us about it? And if you look at literature, the more you read, the more confusing it is, because neither autograft or allograft matches the native ACL. So many factors need to be taken into consideration: a surgeon choice, patient choice, and the patient receiving the graft. So patient-specific approach is something which is really worthwhile. Discuss the pros and cons with your patient and then take a call. This is one article which I would definitely like to quote. This was in 2021, which I came across, where they have spoken specifically about treatment consideration. It's a worthwhile read, won't get into details for want of time, but it definitely gives guidelines on which graft to use in which patient. So what needs to be done? More research. You want more bioinductive scaffolds to protect your graft so that there is better incorporation and cell-specific growth factors that can again help the graft. What you need to do is choose the graft that matches the patient's needs and discuss the pros and cons with the patient. So in simple words, a patient-specific approach, a so-called a la carte approach. Thank you.